Hello and welcome to another episode of Everything Digital Health. I'm Marcus Bohr. I'm a GP, software developer and clinical informatician, and I like to talk about digital health. I think there are other people out there who want to talk about digital health, and so that's what this channel is about. In particular today, we've had a very interesting first ever meeting to talk about Healthcare Archival. I did a quick episode last week to sort of plug this meeting, and the meeting took place today. It was very successful, and we had 35 attendees of the meeting. Lots of interesting discussion about healthcare archival from lots of different standpoints. We had universities, we had hospital trusts, we had individual clinicians, we had suppliers there, everybody with different a take on the issue. I think one thing that was fairly clear was that everybody agrees that there is an issue. There was nobody who felt that this was all dealt with and that there isn't a problem. I think even though we have got some good guidance about retention of healthcare records, it's evident that that's not necessarily what's happening in practice. So I'm just going to do a quick sort of roundup of some of the things that were discussed today. It's not going to be complete. We're hoping to continue the discussion using a forum, and I'll put a link to that forum at the end of the show notes. The Digital Preservation Coalition, obviously I'd like to thank them for setting up the meeting and for hosting us and for doing such a good job of bringing it to everybody's attention. And we will encourage people to join the Digital Preservation Coalition's listserv, which is their email newsletter type of thing. I will include information about that in the description as well. For now, I'm just going to go on to some web pages that I think I can sort of talk to and have a general chat around. So this one I think I showed in the last video. It's talking about the imminent problem with electronic hospital and medical records, and it describes them as endangered, which is their term for, there is an imminent problem and that loss seems inevitable. They have another category above this, which is critically endangered, which means that the loss of data has already happened in the wild, and I would argue that that has happened. We know that big chunks of things like audit trails are lost when medical records are migrated from one general practice system to the next general practice system. And I think in the other video I give a good account of that situation where a company went out of business or left the market, and so the audit trail was left on the old system whilst the clinical data, or what they thought was the clinically important data, was migrated to the new system. And the idea that the working plan was that the GP surgery would keep the desktop PC tower, which is what the old system was running on. It was literally on-premise single server type of thing. This is quite old school stuff. That would just stay in the library in the GP surgery and would keep running, and if we needed to check the audit trails, we could go in there. Now, there's the obvious problem with that is that you do get this over time. Systems start to fail. So if the hard disk fails or something on the main board fails, then that machine is unusable. We also lose access to the applications. Operating systems become obsolete. All of that is not a managed risk there. That's just being left to sort of sort itself out. But the other thing that's not really been being considered is where the GP might be in some way a nefarious person who has an interest in getting rid of the audit trail. And a good friend of mine, Mary Hawking, who is a GP in Dunstable, or retired GP from Dunstable, mentioned this at a recent meeting of the British Computer Society Primary Healthcare Specialist Group, that if you wanted to get rid of your audit trail, you could just migrate your system and then destroy the old PC and claim there was an accident, pour a cup of coffee into it, and it's gone. And now those audit trails which can prove that you were maliciously editing parts of the medical record when you shouldn't have been, that's now gone. Now, admittedly, we don't have on-premise systems anymore in general practice, but the principle remains that if you're not migrating the audit trail, where is the audit trail? And I don't think we're adhering to the letter of even the code of practice that we do have. Talking of codes of practice, we have some of the people who were on the call today pointed out that there is this in the Scottish Government. They have a health and social care records and management code of practice, which is excellent, and it was mentioned that we probably have something like this in England, and we do. So this is the NHS England Transformation Directorate Records Management Code of Practice. It's a nice web-based document. It's fairly recently updated, I guess. And it does consider some of these things. It even mentions the National Archives and the Digital Preservation Coalition. And it's great in that regard. It brings together some of the things that we need to know about handling records. You know, where should they be kept? How should they be kept? When do they need to be deleted? But it's incredibly complex. So if you were to read to the entire document, you would be an expert in records management. Problem is that the people who are implementing a new GP system or a new computer system, they are not necessarily an expert in records management. They are not. We can't possibly expect them to read all this and correctly implement everything that's written in this document in code. So surely we're going to have to give them a more machine readable or executable policy than just writing. Creating this is a step forward, but it's still not everything we need. So including things that are kind of a bit contradictory. So, you know, we've got Section 5 management of records when the minimum retention period is reached. So you then need to decide you've reached the retention period, which is set out in Appendix 2, so go somewhere else to find out what that is. Then appraise each record to decide, does it need to be kept for some other reason? So it has potential historical or social value. Well, who decides that? And then there's a section at the very bottom which says, if we've said you must delete it, but then it turns out that it's actually something you should have kept because it's part of an inquiry. So on top of all of those retention things, there are public and statutory inquiries, for example, the infected blood inquiry and the COVID-19 inquiry, either of which might mean that you've got to keep the records. And this is all very well, but what if you delete a record today and tomorrow you find out that it's part of an inquiry? I'm sort of starting to think that deletion of records is the wrong way to go about this, and we should actually be instead encrypting records and trusting the keys to specific individuals so that we can say, yes, we've still got the records, they're just encrypted, they can never be read again unless there's a reason to unlock them, such as the next inquiry that comes out and adds to this list. I mean, we've got the Lucy Letby inquiry. Well, that was announced in 2023, so surely there were records that may have already been lost, or perhaps not in Lucy Letby's case, but in many other cases where somebody that's not a child, for example, might be their record might be relevant for an inquiry. So it's great that we have this, but it is a bit worrying that so much of it is not being adhered to. Same document, I just highlighted this section, which says that the amount of work required to maintain digital information as an authentic record must not be underestimated. No shit. For example, it might need to be accessible for decades, including an audit trail to show lawful access and maintain authenticity. Well, that means that our own records management code of practice is being openly flouted because a lot of the audit trails are being lost as we move from system to system. There is also other information that's being lost that affects the integrity of a record and the usability. So an example of usability is if we have a record that was accessed through a particular application and then the manufacturer changes the application, perhaps it's an upgrade, great. We get to look at that same data but through a new application. But the way we see it might have changed radically. And if I was in this position of defending a medical legal situation and I'm looking at the data through the new system, how do I know that that's exactly the same view that I got through the old system? We see this kind of problem raised very frequently with out-of-hours GPs, for example, or it's often practitioners that are accessing some part of somebody else's medical record through a portal. So it can be things like summary care record or whatever regional care record has been set up. We don't keep logs of how things looked to those clinicians. So, for example, if you were looking at a record through a portal and it doesn't show you a critical piece of information, you go ahead and do something that harms the patient. Perhaps you prescribe an antibiotic that they're allergic to because it didn't show you the allergies. But then later on, they fix the bug and the allergies are now correctly shown to the users. When you go to court, it's going to look like you saw the allergies and you're going to have absolutely no defense apart from very vaguely invoking doubt on what you saw. I think you'll be told, well, it very clearly shows the allergy here, doctor. You didn't see that, didn't bother to look, didn't dig around in this record, and therefore you can't defend yourself against what is a faulty record, not faulty care. All of this is complex, and not all of it is a pure archival problem, but I think if we solve some of the stuff that's to do with actually delivering good quality records that don't degrade over time for the purposes of direct care, archival will sort itself out. Because I think if we can maintain a record that is lossless over the lifetime of a patient, we probably would have the technology to make it continue after the life of the patient, and then it becomes a matter of the choices we make and the choices the patients make about how long they want their records to last. Do they want to donate them for research or to historians after their death? I mean, that should be up to the patients, really. Certainly they should be more part of the discussion than they currently are. Mentioned in that document is some National Archives stuff about digital continuity, and I just thought I'd show that. But I think this is much more about assessing the current state of your maturity in terms of digital continuity, and I don't think it really helps us in a technical or very implementable way, because our problems are actually quite significantly to do with the technical side of things. One of the areas that came up in discussion today was that a lot of archival, if you go and speak to someone from the National Archives, for example, that archival relates mostly to files. So there is a lot of file-based archival. That stuff seems more understood than database archival. And in healthcare, we've got a lot of databases. So the vast majority of the patient data we're talking about is in relational databases inside proprietary systems. So we don't even really see inside those systems to know how they're constructed. We just have to take it for read that the vendors know what they're doing. But archiving a database is either a very complex thing of keeping the entire application and its database and all that kind of stuff going somewhere, or rendering it out as some kind of file, which I know there is some experience in the digital preservation community with turning a database into a file and still maintaining some searchable element to that, some usability as a database. But of course, without the application, it's kind of pretty useless as well. So it's an incredibly good day for Healthcare Archival in that we've agreed that we have a problem and we need to start talking about it. But the scope and scale of the challenge is absolutely terrifying. It's huge, and I think we're going to have to think differently than we're currently doing. Leaving all this to the vendors is not appropriate. If nothing else, for the reason that by the time you might need to sort out the digital continuity, a vendor may have decided to leave the market, they might have been acquired, or they might have gone out of business, or they might have undergone a complete existential failure due to a cyber attack, for example. And at that point, you needed to have your digital continuity outside of that. I don't necessarily trust that our national organisations are up for this either, because apart from creating codes of practice, they're not very good at doing technical things. One final thing, which is particularly pertinent in terms of our retention, is Microsoft Teams and NHS Net, NHS Mail, because increasingly we're using these tools for some of our clinical work. We have organisation-wide NHS Mail, which is essentially Microsoft Outlook delivered, and we have Microsoft Teams across the entire NHS. And I was just looking at this document, the Data Retention and Information Management Policy for NHS Office 365. And actually some of these retention periods are worryingly short, bearing in mind that we're using these Teams channels and things for multidisciplinary team meetings, for lots and lots of our operational work. And so it's entirely possible that some of the discussions that happened in a Teams channel could be related to specific patient care. And even if you've got a policy that says at the end of the MDT we write a quick summary and we put that in the patient's records, which is probably what you should be doing, what if the nuance of the message was misrepresented? If somebody mis-summarizes me and puts something in the record that I didn't say I would do, but has now been summarized in the record, it looks like I failed to do something that I said I would do at the MDT. And the evidence to controvert that would be in my Teams channel messages, which only last 180 days, which is not very long. Other things, SharePoint. So this is the place where we keep a lot of our operational documentation and, guidance and internal policies and things. We put them in SharePoint and they're gone after half a year. I'll put all the links to all these documents in the show notes, but I think it's just worthy of consideration that we're running a lot of the NHS on this stuff, but we've got quite short retention policies, and that's probably been informed by a thinking that this is just organisational internal discussion, but it is now increasingly being used for clinical purposes. So if you're running a multidisciplinary team or any other kind of decision-making service, and you're using any part of Office 365 or NHS Mail for it, how do you know that it'll be there when you need that archive to be able to defend yourself? How will we investigate criminal allegations if there have been such allegations, inside these systems? And it's clear that this policy hasn't been in contact with the other policy about care records, because I think it is a grey area where we're using NHS Mail isn't necessarily regarded as the care record, but should it be? And if there's going to be a hard firewall between the two things, we need to make that absolutely explicit so that the patient's record is always in the right place and is retained for the right period of time. Lots to think about there anyway. I'm really just recording this as a bit of a follow-up because it's been an interesting day, and hopefully made a little bit of progress. I will put links in the show notes to all the documents that I've linked to. Much more stuff was discussed today, and I think we probably will do some more videos about it for those that are interested, talking about healthcare archival and the problems thereof. But for now, I'll sign off, and I'll see you in the next one.